I get to introduce Phil Kalra, who's a practicing nephrologist, who's also an investigator, pushing the frontiers forward, but who's been introducing heart disease and the kidney. And he will take, would you entrust your heart to a nephrologist? Phil, they've answered already.
So, first of all, thank you so much to John and Derek for the invitation. It's a real honor to be here. So thank you very much, and for the titles as well. Now, first of all, I'm going to make my disclosures very clear. I love the kidneys, but I also love the heart as well, as you can see. And before we get going, I think it's important to set the scene with a big international survey. You know, we asked thousands of clinicians around the world, what are the most important organs in the body? And this is what the survey came out with. First, the left kidney. Second, the right kidney. But, you know, you cardiologists should be proud of yourselves because third came the heart, and it was before the brain. But, you know, we recognize that there are a lot of diabetologists here, and, you know, you mustn't be so ashamed because you came 20th, midway between the rectum and the bladder. Nonetheless, you'll recall that when we were all studying away, we're all physicians, when we were studying at medical school, there was that bunch of people who used to prop the bar up. They were the prop forwards at rugby. I don't know what they linebackers in the US, I guess. And of course, joints, bones, and other miscellaneous bits come 57th in the list. And so this prevents me having to make the joke. What is the definition of a double-blind randomized clinical trial? 2 orthopedic surgeons looking at an ECG. So to really get going with the serious stuff, we've known for a long, long time that cardiovascular disease is a major problem for our CKD patients. So this data on the left is from the Kaiser Permanente population in San Francisco, over 1 million patients, showing that as in non-dialysis CKD, as GFR drops from 60 mils per minute all the way down to stage 5 CKD, there is a stepwise increase in both mortality and cardiovascular events, so that less than 15 mils a minute, you're looking at something like an 18 times increased risk of both of those events. And the picture is even more stark in the dialysis population. This age-old slide on the right, which is cardiovascular mortality in dialysis, uses a logarithmic scale and shows the huge gap in the young patients on dialysis, men or women, versus the general population. You're looking at something like a 100 times increased risk of cardiovascular mortality for a 25-year-old on dialysis. Admittedly, that was 20 years ago. The outcome has not really improved that much. And along the top, you can see the annual mortality of that age group on dialysis. So in the UK, the average mortality of a typical dialysis unit would be about 14%. So obviously it's age-related, and 30% in the patients who are aged, say, 70 years old. So a big, big problem. So cardiovascular disease enriched in our population. So with that backdrop, you would expect that a study like this, so this is the 4D study from Germany, so I won't try and tell you what the 4D stand for. One of them is D, which means the in German, but the others are diabetes, dialysis, and Deutsch as well. So anyway, this picked the highest risk group of patients that we see in dialysis. They are diabetics on dialysis. The average survival is something like 27 months. And they randomized them to placebo or atorvastatin, admittedly you might say low dose, and it was quite a few years ago, but look at the outcome of the study. So the primary outcome was a composite of cardiac death, non-fatal MI or stroke, mean follow-up of 4 years, and there was no difference between the two groups. So what is going on? Some of you, the diabetologists, might say, well, actually, they should have started their drugs not here, but somewhere over here on the wall in their continuum long before dialysis, and no one would disagree with this. But clearly something else is going on. So when I was a kid, a registrar, and going to great meetings like the American Society of Nephrology, we were always told that our patients had accelerated coronary artery disease. So We now believe that that's not the case. It's not accelerated coronary artery disease as you cardiologists would know it in the general population, atheroma rich, etc. But we recognize that the prevalent lesions in our vasculature of the kidney patient is arterial calcification, so with medial calcification, arterial stiffness, and that begetting structural cardiac disease, as you'll see. So this is data. We've got really good data systems in nephrology, even if we don't have large RCTs with positive outcomes. More of that later. But this is the US renal data system, and remember in the US we're looking at a dialysis population of over 400,000 compared to 27,000 in the UK. And you can see that the causes of death are, of cardiovascular death, only 12% were MI, heart failure 15%, and then this vague group, which is the biggest group of all, 70%, with sudden cardiac death, with cardiac arrest, arrhythmic death, more of that later on. So when we come to consider the cardiovascular pathology of our patients with advanced CKD, we've got traditional risk factors that we're all aware of, like diabetes, hypertension, dyslipidemia, smoking, etc. But we also have a series of unique parameters in the dialysis population, all relating to the bone axis, so low vitamin D levels, hyperphosphatemia, duration of dialysis, calcium excess, and chronic inflammation, oxidative stress, sometimes provoked by the dialyzer membrane, for example. So I'm obviously going to try and persuade you during the course of the next few minutes that, as a practicing nephrologist, I know a little bit about the heart, and that's why you're going to entrust the heart to me. So this is how I'm going to structure the talk. I'm going to tell you a little bit about to summarize what we know about these different areas and why they're important. So first and foremost, structural heart disease is definitely very, very important. So we know that patients starting dialysis, something like 60% of them will already have a great elevation of LVMI, so they'll have left ventricular hypertrophy, and about 15% will have left ventricular systolic dysfunction, and only about 20% will have normal hearts. And this data from Carmine Zuccali from well over a decade ago showed that in just a small population, and that's often the case in the renal trials, 160 dialysis patients in Italy, that the patients who had the greatest gain in LVMI during a 12-month period, as adjudged by 2 echoes, baseline in 12 months, were the ones at greatest risk compared to those who had minimal changes. So LVMI undoubtedly is a major risk factor. And even the nephrologist is getting wise to the fact that when we're talking about left ventricular hypertrophy, we're not talking about good skeletal muscle hypertrophy, we're talking about fibrosis, severe fibrosis with rarefaction of capillaries, poor perfusion, and really badly contracting muscle, and as seen in these later T1 imaging scans at MR as well. And some of us are even trying to do studies in this population, and this is work from our own group where we've been using speckle tracking echocardiography to look for more subtle abnormalities of left ventricular systolic function, notably the global longitudinal strain. And for the non-cardiologist, just to explain that, your strain is good if it's around minus 20%, meaning that your contractile function is better. So here, the median for our population of 220 patients was minus 13.5%, and these are patients above the median, meaning they're more positive and therefore they've got worse strain. And you can see the difference in mortality just in this small single center study. And to just take the key bits out of this complicated slide, risk of all-cause mortality was related to age, as you would expect, also to LVMI at baseline, and to the pulse wave velocity. So the faster the pulse wave velocity, more about that later, the worse the outcome. But cardiovascular specific mortality was related to GLS, the worse of the GLS. So when we look at the potential causes of structural abnormality in our population, there are many. And this is why it's been so difficult to actually find positive results from our outcome studies in dialysis patients where we're looking for cardiovascular or mortality benefit. There are so many contributing factors. So classical things like hypertension, coronary artery disease, upregulation of the renin-angiotensin system, volume overload, and anemia, oxidative stress and inflammation. I've mentioned those already. We have got a unique phenomenon that has been studied by a few groups, and that is during dialysis, if you actually perform echocardiography during the dialysis period, you can find about a third of the population will have various stunned segments of the myocardium, which actually reverses afterwards. And those patients are the ones at greatest risk at 1 year mortality of arrhythmia, etc. So more of that a little bit later on. But there's also another unique pathogenesis going on in the kidney patient, and it relates to something we now call the CKD, mineral and bone disease axis. And enveloped within that, we have PTH, vitamin D deficiency, leading to arterial calcification and vascular stiffness. And FGF23 I'm going to tell you about in just a moment. So that moves us nicely onto vascular calcification. So I'm again going to show off to you to show that I could report a coronary angiogram for you. So on the right-hand panel, we've got a mitral valve replacement. And here we've got the left main stem. We've got the left anterior descending coronary artery and the circumflex, and there at the bifurcation of the vessel, we've got a large plaque. But on the left-hand side, you can see already that before the contrast has been inserted, we can already see the outline of the vessel due to vascular calcification. And this isn't just a minor problem. At least 60% of our patients start dialysis with vascular calcification. So why is this relevant? Well, we can do pulse wave analysis, and you've seen all the various equipment like vicors and sphygmocors, and we use these ourselves in research areas. But so in the young compliant aorta, the pulse wave, which of course is not the blood flow is going to be something like less than 1.5 meters per second, but the pulse wave travels along the outside of the aorta, and here it goes in a young person, nice compliant vessels, hits the periphery, bounces back, and augments the diastolic coronary filling. And then in the patient who is old, who is calcified, the kidney patient, they have a much faster pulse wave. The wave hits the periphery, bounces back, and interferes with diastolic coronary filling. The heart is pumping against this rigid tube, this non-elastic tube, and hence predisposes, we think, to some of the pathology that I've already described, the LVMI, the dilatation, the fibrosis, etc. So we've known for almost 20 years that it does matter. So this was some fundamental studies from France, from Gerard London's group, showing that as pulse wave velocity in a dialysis population of 241, as pulse wave velocity increases or calcification score increases, then it begetted a much worse outcome for the patient. So here, calcification score of 4 versus 0, we're looking at a 6-year survival of just 20% versus 95% if there's no calcification. So it seems to matter. Whether it's the cause or not is another matter altogether. We recognize that in normal health we have inhibitors of calcification. So we have phetuin, matrix GLA protein, pyrophosphate that stop calcification occurring. But unfortunately, these parameters actually drop in the circulation of the dialysis patient, and promoters take over, tipping the balance in favor of calcification. Here, coronary calcification on the CT of the heart. This is calciphylaxis in the skin, which is a horrible condition we occasionally see in our patients. We've known for a long time that phosphate has this J-shaped relationship with mortality of our dialysis population. So this is data from 40,000 patients, again in the United States, on dialysis. Jeff Block was the author of this, showing that as phosphate steadily increases above 1.6 millimoles per litre, there is an increase in mortality risk. And we have this J-shaped relationship because we find in a dialysis population, those with the lowest phosphate or the lowest cholesterol, in another slide, would be those people who are malnourished, and they've got a poor outcome too. But does this mean that phosphate is killing our patients? It doesn't mean that at all. This is observational data. So what might be going on is, I need to tell you about FGF23. So for the non-nephrologists, fibroblast growth factor 23 is a newish hormone that is made, well, newishly discovered, that is made in your osteocytes, that is a phosphaturic hormone. That means that it works on the renal tubule to prevent the reabsorption of phosphate. So it increases phosphate excretion. It relies upon an obligate co-receptor called Clotho. You may have heard of that. And it's becoming all the buzz in many of the meetings that we go to, and there's much science going on. And this is, again, a study from the US dialysis population showing that higher levels of FGF23, those in the highest quartile, had 6 times the risk of death compared to those in the lowest quartile. So again, observational data, does it matter? Well, it's been taken to another level in some quite elegant animal studies, preclinical studies. This is a group of Miles Wolf, and it was published several years ago now. But I like this because this is mouse hearts in cross-section. These given vehicle, these given FGF23 as an intramyocardial injection, and phenomenal changes in LVMI at just 7 days and 14 days. And you know, it seems to be that there's every chance that this could be a pathogenetically important molecule, and there's a lot of work going on at the moment studying that. So moving on from there, what do we know about this arrhythmia and sudden cardiac death area? So this is work from Rob Foley, who works in Minneapolis, used to be a colleague of ours in Salford, actually. And Rob published data from, the United States Renal Data System showing that our 2-day break, the weekend break in the three weekly cycle of hemodialysis, put patients at greatest risk. So after the Tuesday after the Saturday dialysis or the Monday after the Friday, there was an increased risk of all-cause mortality, of cardiac death, of arrhythmias, of admissions to hospital. Everything you want to look at was worse in this break. So we think that there are many factors contributing to that, but we started to term sudden cardiac death as a major cause of this. So with the advent of the implantable loop recorders, we've started to do some studies to look in more detail. So the Reveal devices that are surgically implanted, or now injectable devices that are quite small and can transmit data back to computers, etc. And there have been 5 international studies published, and this is hot off the press, this data. It's come out in this month's version of Kidney International. So the largest study comes from the United States, coupled with India, by Ray Chowdhury, where 66 patients had ILRs, but there are notable studies from Australia, which was the first one, 50 patients, and our own. So my brother Paul, actually, and Rob Lewis, who's the nephrologist in this study from Portsmouth, inserted 30 ILRs. The key data that comes out of this, and actually I did a review for this paper in KI, and the table is from our article. Basically, it shows that instead of tachyarrhythmia, which is what we were expecting to find, the key abnormality seems to be bradyarrhythmia. So something like 15 events in all of these small studies compared to 2 tachyarrhythmic deaths seems to be the message, talking about maybe the fibrosis that we see in these patients with LVMI. Other notable points are that in our study in the UK, 10% of the patients required a permanent pacemaker during just 18 months of follow-up. In the US study, the MID, there were 5 patients who required a permanent pacemaker, suggesting to us we should actually maybe look a bit more often with the simple tool of ECG, which we don't tend to do. Maybe 6-monthly ECG could be the rule in the future. So what are we trying to do to improve things? Structural heart disease, well, we haven't got a great deal of evidence, and I'm sure Paul will be sort of hammering that point home. But we've got some evidence from RAS blockade and BP control in terms of improving the structure of our hearts. We've got anemia therapy, but there's no outcome positive data relating to that. We've got extended hours dialysis, more of that in a minute. So there is a bit of evidence. Cooling of dialysate is an interesting thing that might reduce stunning. It's been shown in some pilot data. There's an ongoing study looking at that, and people are playing around with finding FGF23 antagonists or receptor blockers as well to try to interfere with that axis. In the vascular calcification area, no studies reducing phosphate have led to any beneficial improvement in cardiovascular outcomes. Similarly, a big study in hyperparathyroidism control also showed no benefit either. We have got some new agents that inhibit calcification that are exciting. When it comes to sudden cardiac death, you know, it's a very much an open area. We need a lot more data about this. We need to get better risk stratification for our patients. It's really, the door is open with that one. So just very quickly, as of Friday, this came out. So this is our National Institute for Health Research HTA program in the UK. And so the nephrologists had called for this study, and it was announced on the 5th of April, which was last Thursday, wasn't it? Extended duration hemodialysis trials. So that's going to be very interesting. We're going to develop some of those. There was this frequent hemodialysis network trial published about 7 years ago, 250 patients randomized to either 6 daily dialysis sessions per week versus the traditional week, and it showed a significant benefit in terms of LVMI after a year, so a drop in increase in LVH by 40% and an improvement in mortality by 30%. Daily dialysis is expensive. In the UK, we can't offer it to many patients. It's only people who really dialyse at home can do that. We have, I mentioned, we've got new products. So we have, this is a drug from Sanifit in trial at the moment, which can reduce vascular calcification in theory, and it binds to hydroxyapatite, reducing calcification. Exciting evidence at the moment. Moving very quickly on to coronary artery disease, I'm not going to say too much about this. We recognise as nephrologists that the difficulty of trying to diagnose ACS in patients who already have high troponin levels, many of them do. And so there's a lot of work going on trying to assess the specificity and sensitivity of troponin I or troponin T. It is a big area and difficult, but there is work going on. That's all I'm going to say about that. The second thing is, well, in multi-vessel coronary artery disease, what is the best means of treating the patients? Is it with PCI or is it with coronary artery bypass grafting? And I think in patients with such advanced disease, this meta-analysis of 11 studies involving almost 30,000 patients probably gives us the answer. So if we look at short-term all-cause mortality, so within 30 days, then definitely PCI is favoured. However, when you look at long-term mortality, then coronary artery bypass grafting definitely seems to be the favourite. So I think most people are pushing towards the latter for the treatment of patients with multi-vessel disease. So one thing that we have done in the area of vascular disease is this is our biggest trial in nephrology, and I'm putting it up there because it was positive. So the SHARP study was actually run out of Oxford in the UK, 9,000 patients, half of them got treated with simvastatin and ezetimibe combination, the other half with the placebo, and what they showed was that there was a 16.5% reduction in non-fatal vascular events, so myocardial infarction, stroke, ischemic stroke, and PVD. The effect was much greater in the non-dialysis patients than in the dialysis patients. I'm going to say a little bit about renal vascular disease as I come towards the end of my talk. So my main interest actually in research has been in atherosclerotic renal artery stenosis. So I was the lead nephrologist for our other big trial coming from renal medicine in the UK. So this was called Astral, and our primary primary outcome measure was renal function over time. So this was 806 patients, half treated with stenting, half treated with best medical care, published in 2009. And you can see that the primary outcome measure, which was renal function over time, was no difference between the two groups, with taking the all-comers going into the trial. Following that was the US-led CORAL study, which was 947 patients, again randomized one-to-one to best medical care or best medical care plus stenting. The primary outcome measure was different. It was a composite of death, cardiovascular events, dialysis. But you can see, again, there was no difference in the two groups. The two studies were slightly different in that the UK study had a GFR of 40 on average. The US study, it was 58 mils a minute. So they had probably earlier disease and more hypertension. But nonetheless, Chris, who's a cardiologist, took it upon himself as the editor of this journal to have a pop at, firstly, Astral. I've got no chips on my shoulders about this at all, as you can see. And he even had a go at his fellow countrymen, calling the CORAL trial the Chicken Little of randomized controlled trials. But in fact, there's no doubt that we made a difference. This is Medicare data showing that in 2004 there were 30,000 renal stent procedures performed in the United States per year, and after Astral it dropped to a third. So this really did make a big difference. And so what have we learned from the renovascular RCTs? In both CORAL and Astral, we did take all comers, but that's what was going on in some of the interventional cardiology clinics in Germany and other parts of Europe and North America. And we now know that the oculostent reaction has now been inhibited, and we are avoiding drive-by cardiological stentings. At least that has come out of these trials. I'm going to finish with heart failure. I'm going to say a little bit. We're all now aware of the Ronco classification, and we're drawn to this cardiorenal syndrome. I'm going to say very little about this because this is a main interest of Paul's, heart failure syndromes. Suffice to say that, yes, we can work together, cardiologists and nephrologists, to offload the patient with heart failure. And I'm going to finish with one case just to try and persuade you that you will entrust me to look after your patients' hearts. So this was a patient of ours, a 65-year-old lady under the care of the cardiologist with 3 episodes of acute pulmonary edema in 12 months. She had a severe hypertension on 3 agents. Her echo showed moderate systolic dysfunction. She was a claudicator, so she had bad vascular disease elsewhere. Her GFR plummeted from 60 to 22 mils a minute over the course of just 15 months. She had severe bilateral renal artery stenosis. And here you can see her angiogram. That's after stenting, but you can see 2 tight stenoses there. She had a 3rd one here. And this lady, if ever there was going to be a patient with flash pulmonary edema who was going to get better with a revascularization procedure, it was going to be this lady. And sure enough, we put in the stents. Now, my colleague, Tina, who's in the audience, was then one of my research fellows, had a sharp eye for a paper at that time in her PhD days, and she realized that we should be doing a cardiac MR before and after this procedure, because there was very little in the literature. And this is what actually happened. I'll tell you the cardiac MR data in a second, but essentially we did single kidney GFR. That means chromium-labeled EDTA plus DMSA scan to show split renal function. And you can see that the right kidney, which was pretty big, 9 centimeters, had no difference after stenting, whereas the left kidney had a doubling of the GFR. In that particular kidney. So great outcome, but look what happened to the heart. This is phenomenal. So at 1 year, she was down to BP 125/75 on 2 agents, but at 4 months, on the MR scan, so good repeatability of this scan, we had a halving of her cardiac congestion, her left ventricular end diastolic volume. The LV mass dropped by a 1/3, and even the ejection fraction significantly improved, just in 4 months, a phenomenal improvement. So, last slide. Would you entrust your heart to the nephrologist? Well, We are learning a lot, but we recognise that we need more evidence. The problem is, as I mentioned before, because of our multifactorial pathogenesis of the heart disease in the patient with on dialysis, it's very, very difficult to actually pull out one particular parameter that is going to make a difference, and that's blighted us over the years. And at the moment, our current approach should be to treat all risk factors, blood pressure as early as we can, RAS blockade, anemia, phosphate control as early as possible. So we need more action. We appreciate that. Cardiologists do provide actions. We try to think a lot. We think we do. Lots of ideas, some actions, hopefully a lot more on the way. Thank you very much.